The one debate I'm not going to win is definitely Chennai in Potrikanga. I'm definitely not from Chennai, I'm from Coimbatore. It's a great debate, thanks for the invite, and it's very relevant in the current context. So I've got no conflicts of interest to declare for this talk. The objectives for the next 10 minutes is to break some myths about oral hypoglycemic agents in pregnancies. A lot of people give a lot of myths, especially in our setup, and that filters to audiences who propagate that to other people. So we are going to break some myths, and I'm going to talk predominantly pro-metformin. I'm not going to talk too much about glibenclamide and acarbose. There is some new data which says that it may not as good as it sounds. And in the metformin bashing, unfortunately, I see key opinion leaders. I've seen senior endocrinologists go on stage and say metformin causes rupture of labor, it's a dangerous drug to use. And they're saying the same thing. Metformin is dangerous in pregnancy. And when the herd is running towards a cliff, the one running in the opposite direction always seems crazy. But it's great to have a scientific debate rather than trusting people's own opinions. So it's a great stage for us to debate. And the flip-flops no narika. I've seen senior obstetricians telling me that they are comfortable using metformin and PCOS in the first trimester, but not comfortable using metformin in GDM because they think it's not indicated and it's dangerous. Come on, you use it in the first trimester very confidently for PCOS, and when it comes to GDM, just the name has changed and you say that it's dangerous. So you all know John Kerry, who lost the US presidential elections, when he said, I did vote for the bill before I voted against it. So either you are pro OHA or you don't use it, but let's be clear today at the end of the debate. So I've got a clinical scenario. I would be happy if the audience just raise their hands. So we've got a typical GDM lady given diet and lifestyle advice, but the fasting and the TUA values are persistently high even after 12 to 13 days of diet counseling. Who would say these levels, fasting of 95 to 105 is reasonable, 2 hours is less than 130 to 50, she should continue with diet and lifestyle alone? Anyone? Quickly, I don't have much time. No? Who would say oral agents are absolutely contraindicated in pregnancy? I would never use metformin in pregnancy. Anyone? Madam? 2, 3. Madam, I won the debate. 99% are not raising their hands. Metformin is a reasonable choice. I would start the lady on 500 milligrams BD with the possibility of adding insulin if targets are not met. Anyone? We've got a lot more hands going up. That's good. Huh? Oh, okay. At least they're going in the opposite direction for good matter. And insulin is the gold standard. I'm uncomfortable using oral agents till more evidence. And again, I think there are a reasonable number of hands going up, and I think that's important. Because the 1998 oscillation guidelines clearly told oral agents have no place in the treatment of GDM under normal circumstances. Has things changed now? Has anything changed since the statement? And I think a lot has changed since the statement. And Thiruvalur Arumya solrikkaru, Pazhayana Kadidalum, Pudiyana Pugudalum, Valuvala Thala Vagainami. The old order always changes, giving place to new, and that's nothing wrong in that as far as there's scientific evidence to back it up. And metformin addresses all key endocrine defects in pregnancy. We all know pregnancy is a very insulin resistant state. Now, we end up on type 2 diabetes. Metformin is first but pregnancy number 2, for some reason, we think that we have to be, it's a dangerous drug and it causes a lot of problems. Again, there are valid reasons why one would say that. And pregnancy is an insulin resistant state. So why the hesitancy in using metformin? So I'm sure my debater is going to talk about all these things, worried about placental transfer. It's a new concept, no long-term experience, no randomized controlled trials, big evidence. Is it efficacious? A lot of people need to go on insulin anyway. The worry about metformin crossing the placenta and causing problems to the child, and what happens to the metformin babies. And I think these are all very valid, reasonable concerns that I'm going to address. Placental transfer, I'm not going to argue with that. It does cross the placenta, and that's the only reason why we are having the debate in the first place. If it didn't cross the placenta, I'm sure it would be the first line drug before insulin. Is it a newer concept? No. Number science number Indians found an airplane 3000 years ago. Metformin is not used in 2008. It's been used by Coimbatore group in South Africa, in Johannesburg, for poor black patients who didn't have money to buy insulin. Instead of putting nothing, I'll just start them on metformin. And this paper was published in 1979 with this work from the 1965s to 70s. And they found that metformin, in terms of perinatal mortality, did extremely well. And you're talking about current NICE guidelines. This guy in 1980s told glibenclamide and metformin appears to be safe drugs during pregnancy when properly used. And look at the rates. The perinatal mortality was 17 out of 100 and 42 out of 1000 compared to 364 out of 1000 in the untreated group. Instead of not giving anything, these drugs seems to do wonders for these patients. So this concept of it's a newer concept and no long-term experience is absolutely false. It's been used for about 40-50 years now. And in terms of RCTs and meta-analysis, I think the debate will come to a stop if you look at this BMJ paper. I would advise all of you, if you've not seen this now, to go to Google, type in BMJ 2015 Metformin and Pregnancy. And this is hot off the press, which shows that if there is one drug that's favorable compared to insulin in terms of birth weight, that's metformin. Metformin scores over and above insulin, over and above glibenclamide, and glibenclamide performs very poorly compared to insulin in terms of birth weight. And all the studies, the holy grail is the birth weight, and metformin scores much better than insulin. So if you look at the nutshell of the data, this is what they told in this BMJ paper. It's a huge meta-analysis of all major studies, about 15 studies done on oral agents and insulin. If you compare it with the insulin, metformin is associated with lesser maternal weight gain, lower rate of neonatal hypoglycemia, less pregnancy-induced hypertension. This is an important area because metformin seems to improve endothelial dysfunction and improve insulin resistance, less macrosomia, and more patient satisfaction and preference. And if you compare it with the glibenclamide, again less maternal weight gain, less macrosomia, less large for gestational age patients, and the treatment failure was slightly higher with metformin, but I do note that in the MIG trial the failure was much higher with metformin. And again, I don't want to re-emphasize this point. I'm sure you've heard about the MIG trial, the metformin versus insulin for treatment of gestational diabetes. It was a landmark RCT comparing metformin versus insulin in around 750 pregnant women. And basically they looked at all the neonatal outcomes. And what is the final thing? Both the mother and child are okay if you put them on metformin compared to insulin. And that was the final outcome. And you take any of the neonatal markers like respiratory distress, phototherapy, birth trauma, and admission to NICU, metformin was equivalent to insulin. There was a slight difference in the preterm birth, which we'll talk in the debate later. And this is again a very good paper from Balani in 2009, comparing 100 women on metformin and 100 women on insulin. And they showed less prematurity, fewer admissions to SCBU, and reduced instance of neonatal jaundice and hypoglycemia. And they said it's a very safe alternative to insulin. And what about congenital anomalies? We are worried about this crossing to placenta. Again, our obstetricians use it left, right, and center in all PCOS for, in fact, throughout pregnancy. And there's again a landmark paper which came out in 2014 saying that there is currently no evidence that metformin is associated with increased risk of major birth defects in women affected by PCOS and treated during the first trimester. There's not been a single study which shows that there's an increased risk of congenital anomalies with metformin. And finally, what happens to metformin babies? We are always worried about it. It crosses the placenta and what it can do over a longer period of time. And there are two papers for it. This is from Glerk, who has done quite a lot of original work, and they followed it up for about 18 months, and they couldn't show any growth or motor retardation in babies born to mothers treated with metformin for PCOS during pregnancy. And again, you've all heard about the MIG-TOFU study. I'm sure Dr. Usha Sriram has some data that we don't know about what the longer-term outcomes are. But again, this study looked at all the children born to metformin mothers in the MIG trial. And again, they found that there was no big issue. And if anything, they were wondering whether there was a beneficial effect of metformin to babies in terms of subcutaneous fat. Again, this is a very iffy hypothesis. I'm not here to say that that's what the case is. Things may turn out different later, but at least it's safe up till 2 years of age. And I've had a lot of personal experience using metformin both in the UK as well as India. I was a clinical lead for diabetes and pregnancy in Scotland for 5 years, and these are our published papers in Metformin and Pregnancy, and this was published in 2013 in Apollo Medicine with our experience of using metformin in gestational diabetes. And again, we didn't find too much of any major complications. We had normal deliveries in around 72% of women, and again, all the other complications were very minimal. There was just one congenital malformation, but that baby had Down syndrome with a VSD. So on balance, I just want to say, if you're looking at placental transfer, yes, it crossed the placenta. New concept? No. Used for a long time. No RCTs. We have got the BMJ meta-analysis in 2015 and the MIG trial. Efficacy, at least 54% don't need insulin. If someone tells me that, that's a big number. Congenital anomalies, no evidence. Metformin babies, at least not causing big problem. Is it beneficial? That's a big question, and we've got personal publications. So back to the case, anyone wanting to change their mind about using metformin? We'll leave that to the final thing. So if there's a drug which is easy to use in any setting, it's very acceptable to patient, dirt cheap, no big safety concerns, less weight gain, and less than 50% of women needing insulin, which one do you want to go? I would rather go for metformin rather than insulin. I just want to conclude by saying, please vote for a definite yes for metformin in GDM. Use it as far as you counsel the patient, document everything in the notes. If you're not comfortable, please use insulin. Insulin is the gold standard. I'm not saying that you don't use insulin, but please don't bash users of metformin. And I've got no personal experience with glibenclamide, and all these American associations keeping glibenclamide above metformin, they are not always right. Thank you very much.